and wanting to be part of the session, can I suggest you come down close to the front so we have a sense of togetherness? A bit of critical mass would be great. We'll get started in just a few minutes. Thank you. And I'm encouraging people, if you are wanting to be part of the session, to come a bit closer to the front so you can have a bit more engagement with our speakers. My name's Chris Bullen. I'm a professor of public health at the University of Auckland in New Zealand, and co-chairing the session with me is Dr. Huan Shitong from Beijing in China, and we have 3 out of our 5 speakers have made it here. This afternoon we hope there might be at least one more to join us. And the focus of this short oral abstract session is on tobacco cessation and integration in TB control. And we've got 2 speakers talking about the integration with TB programs, and 1 speaker talking about cessation more generally. And interestingly, actually, all of the settings in which the research that they'll be presenting is from India. So we could have retitled this Tobacco Cessation, Integration and TB Control in India. But that's by the by. So each of the speakers will have 6 minutes. We've got an hour and a half allocated. We have fewer speakers than we'd hoped for. So we'll have lots of time for interaction with each of the speakers following each presentation, and then there'll be some time at the end, of course, for interaction. So as we listen to each of the speakers, think about questions you have to ask. Don't be shy to come up to the microphone there and fire away your questions. So thanks very much for coming, and as I say, if you can be brave and come a little closer to the front, that would be fantastic. So I'm going to hand over to my co-chair to introduce the first speaker.
Okay, good afternoon, ladies and gentlemen. Now we will start our session. The first speaker is Om Bara. He's from the Union, and the title is High Prevalence and Nicotine Dependence Among TB Patients Who Are Smokeless Tobacco Users Compared to Smokers.
Good afternoon, everyone. It's my privilege to be here and present my topic on integration of TB and tobacco. So my topic is relevant to today's world and newest technologies for dependence, which is still a newer topic to be taken up by many for research, but it has fascinated me since 3 years, and I'm presenting a conglomeration of my work that has been not from like last 1 year or 2 years, but it's from 3 years. We have conducted the study in around 12 districts, and so is the study. Going with the background, dependency on nicotine is the main criteria that differentiates a tobacco user from a non-tobacco user, and usage of any form of tobacco does hamper the treatment outcome of a TB patient. While rehabilitation also, it has been seen that TB is, in India specifically, in TB control, like the tobacco dependence has never been taken into account. And we are still into like counseling procedures and replacement procedures at some higher level of city. And the objective of the study is to describe the prevalence, which brings out a complete differentiation of smoking versus the smokeless tobacco users among TB patients. The study is a cross-sectional study using a pre-tested Fagerstrom test for nicotine dependence, and it's a questionnaire-based study which was been administered to the adult TB patients. And whoever adult TB patient, the study was open. Adult TB patients giving consent for the study were selected, and using stratified random sampling, we took into account 12 districts, 4 from urban, 4 from rural, and 4 from tribal. The sampling was done so as to give it a uniform coverage to three parts. As in India, we do have a marked transition from urban to rural to tribal. A total of 720 patients were taken into account, and out of that, 240 each from rural, urban, and tribal areas. And those patients were taken randomly selected. Data entry and analysis was done by SPSS. So out of the results, the first slide is on the gender-wise and the locality-wise distribution of this TB patients. So we took into account 720 patients. Out of that, like 63% were males, and with urban, rural, and tribal distribution of 30%, 28%, and 42% respectively. So we did have a greater proportion of males from the tribal part of India. And out of the 266 females, we had 42%, 30%, and 28% residing in urban, rural, and tribal parts, females. So the study specifically was well distributed across the 3 geographical parts of India. Going by the socioeconomic status and the locality we made a analysis, and we found out that out of the 720 patients, 57% belong to poor socioeconomic status, and out of that, 68% were tribal, 62% were rural, and 41% belong from urban domain. And 26% and 17% represented the upper middle class and the lower middle class respectively. Now the crux of the study is the prevalence, and we got some good results in terms of science, but yet it's discouraging for a public health professional. So the prevalence of smokers were like 16%, 18%, and 19% in urban, rural, and tribal areas. It is slightly in accordance with the GATT study, like the Global Adult Tobacco Survey. But for the first time, we took into account the smokeless tobacco usage. In India, we do have a high proportion of population having a smokeless tobacco usage. And that is most of the times hidden, because until unless you smoke, that's in public, you know that you are having a tobacco. And the behavior analysis of Indians also do have a tendency to hide the tobacco usage, because still in some parts of India, it's a taboo. And out of that, we did a slight differentiation again, according to the urban, rural, and tribal population. We did male and female differentiated. So found out that it was, in urban population, it was 13% smokers male and 3% were female. In rural part, it was exclusively 14% male. But we also had a demerit that, like in rural part of India, most of the ladies are not open to say their exact status. So we do have according to the data provided from the patients, it was done like that. In tribal patients, we found an astounding 13% prevalence in males and 6% prevalence of smokeless tobacco in tribal females. Going by the smokeless users, we had for the first time we got results of more smokeless tobacco users than smokers. We got around 15% smokeless tobacco users male and 7% female, and 12% in rural areas, 6% female in rurals. In tribal part, we had a 14% proportion of TB patients having smokeless tobacco usage and 8% females. Now, of all the smokeless tobacco users, they had a severe dependence of 79% in smokeless tobacco users and 67% in smokers. Among smokeless tobacco users, 18% and 3% accounted for moderate and mild dependency, whereas 22% among smokers. And nicotine dependence was significantly associated with age group, locality, alcohol use, and duration of tobacco use. In India, we do have a plethora of many types of tobacco. We also do have a huge proportion of population having this behavior of using smokeless tobacco or a smoke. And in this study, we found there was a severe dependence among TB patients, which is slightly alarming for the National TB Control Program. And we do offer cessation services like counseling only at our TB centers, but that is still inadequate. And we do need go for the nicotine replacement therapies at the National TB Control Program for reducing the burden and controlling the morbidity and mortality. Thank you. That's all. I think I've completed on time, sir.
Okay, very good report. Now we can have a few questions. Anyone who have questions, you can just look in before the microphone here. Any questions?
Well, I've actually got a question. And that's really about, you talked about smokeless and smokers. Are there not groups of people who have both smoking tobacco and smokeless tobacco, so dual users? Did you measure the proportion of people who use both products or just either or?
Yeah. We do have a aggregation, means if you take into two loops, there is definitely a loop overlapping each other, having a common a behavior of having a smoke when the smoke is available and having the smokeless tobacco when it is available. But that percentage is very less. It is around 3% in my study. That's why I have excluded those samples who had this overlapping behavior of smoke and smokeless tobacco.
Okay, thank you. There is a lady. Please identify yourself and then make the question. Thank you.
Hi, I'm Omara Dogar from the University of York, and thank you for a very informative presentation. I only have one question, which is there any literature on the association of smokeless tobacco use with tuberculosis, or have you looked into doing some such work?
That's a nice question. The association of smokeless tobacco uses with TB prevalence, means till date we have not found it out. But yes, the association has an important role with the treatment outcomes. So we have seen, smokers, we do have some of these perfect studies which shows that the treatment outcome differs. But yet we are about to come out with a study which shows that smokeless tobacco user has a negative treatment outcome. Might be this is the study which is going to be published with a treatment outcome modality also. This study I have presented only showing the role of dependence, but this study has another phase which shows the treatment outcome. So we need to wait for that.
Okay, thank you.
Thank you.
One more question, which is, the implications of your research, finding this high level of dependence, which is one thing. Obviously, tobacco product use is moderately high, not as high perhaps as in some countries actually, in this population. Do you think that some of the patients, because they had the diagnosis of TB, have already stopped using tobacco by the time you saw them in the survey, and that is why the prevalence was around 16 to 18%? Or is that what you would see in the wider population, apart from TB patients?
Pardon, I would like to hear the question again. It's
okay, so that's right. So the question really is the prevalence of smoking or smokeless tobacco use in the study population, the sample that you had in your study, is it different from the general population, or do you think that people having had the diagnosis of TB may have already decided to quit because of the threat of a lung health problem? Or are those prevalence rates essentially the same as in the general population?
Yeah, more or less it's the same, but not yet reported.
It's just that they seem quite low compared with many other countries in Asia.
Yeah.
So
more or less
it's a good starting point, I guess.
Yeah.
Very good, thank you.
Thank you.
Okay, thank you.
Great. Well, we're going to continue the theme of smokeless tobacco. So our next presenter is Dr. Aishwarya Vidya Sagaram, and she's from the University of York, and she's doing her PhD looking at measures of dependence in smokeless tobacco users. So thanks very much.
Hi, very good afternoon, and thank you for having me here. I must apologize for my voice. I'm still recovering from a sore throat, but luckily it's only a short presentation, so you don't have to listen to it for long. My name is Aishwarya Vidya Sagaran, and I will be presenting on the use of the tobacco dependence screener, which is a 10-item questionnaire to diagnose smokeless tobacco dependence in India. This work was carried out as part of my PhD, and my supervisors for this work are Drs. Kamran Siddiqui and Mona Kanan from the University of York in the UK. A 2014 systematic review of tobacco dependence measures found that measures have been developed almost exclusively around cigarette smoking, while some of these have been adapted and validated across other tobacco products, including smokeless tobacco. But even the few cross-product validation studies have rarely been carried out in high-burden settings such as India, where the most recent GATS conducted in 2016-17 still shows smokeless tobacco to be the predominant form of tobacco use in the country among both adult men and women. India has an overall estimated 220 million adult users of smokeless tobacco, the highest numbers found anywhere in the world, and these users face about 74% of the global burden of disease due to smokeless tobacco use. So to study the use of the tobacco dependence screener to diagnose dependence among ST users in India, we back-translated and administered the smokeless tobacco adapted version of the scale in Hindi to 233 adult exclusive smokeless tobacco users in New Delhi who were recruited through a purpose of sampling in a community setting. The scale itself was originally developed for cigarette smokers, and it's based on the DSM-4, which is the Diagnostic and Statistical Manual of Mental Disorders developed by the American Psychiatric Association and the WHO's International Classification of Disease, ICD-10, clinical definitions of tobacco dependence. The scale has a total of 10 questions, as mentioned earlier, with the yes or no response for each item. The sample characteristics are as follows. The mean age of the recruited sample was about 30.53 years, with a near equal gender distribution. On average, participants' age of first smokeless tobacco use was about 18 years, and over 97% of the sample were current daily users of smokeless tobacco, averaging about 10.64 years of daily smokeless tobacco use. The tobacco dependence screener results are as follows, with the total values ranging from 0 to 10. The mean TDS score was 6.46 with a standard deviation of 2.29. The internal consistency reliability of the scale items assessed using Cronbach's alpha was 0.69. And the scores showed significant positive correlations with the ST modified version of the Fagerstrom test for nicotine dependence, which is a 6-item scale and most widely used across the world for measuring ST dependence. The tobacco dependence screener also showed significant positive correlations with salivary cotinine levels, cotinine being a metabolite of nicotine and a widely accepted biomarker for assessing nicotine dependence. While saliva samples were collected and analyzed using the ELISA method for all 233 survey participants, we ran into problems with analyzing 2 batches of the samples, and so the correlation results that I've presented here are only from 1 batch, which had a total of 72 saliva samples. Using the recommended cutoff score of greater than 5, 66.5% of survey participants were diagnosed as being smokeless tobacco dependent using the tobacco dependence screener. And logistic regression analysis showed that a TDS-based diagnosis of ST dependence was significantly associated with longer duration of daily smokeless tobacco use, greater frequency of chewing per day, and chewing within 30 minutes of awakening. So to conclude, our results have shown the tobacco dependence screener to have acceptable reliability and validity to diagnose dependence among smokeless tobacco users in India. These findings are consistent with one other earlier validation study of the tobacco dependence screener among ST users in the USA. I also found the scale to be fairly easy to administer, but further evaluation of the scale would be needed. For instance, I wasn't able to assess a test-retest reliability because of the nature of the recruited sample. I wasn't able to assess the predictive validity of the scale against a cessation as well. Furthermore, right now there is a DSM-5 that has become available, but the TDS is based on the DSM-4 criteria, and so an evaluation of the existing items against the newer criteria may be warranted. These slides show the references that I've used in my presentation. Thank you. Thanks very much.
Great. Thank you for timing so well, too. It was very good. Come on, stay up there. You can't run away. This is really a good example of some high-quality work, I think. And my question really would be, just to start the ball rolling, and if you have other questions, please come up by the microphone, is sort of, so what? How do you see this screening test being used practically in the field once you've done some more work on it postdoctorally?
Right. With this scale, because it was with dependence, assessment of dependence itself in general, it's quite a under-researched sort of area for smokeless tobacco in India. And with this scale, it's been used as a diagnostic scale, so people use it to I suppose, tell a user if they are dependent on the smokeless tobacco or not, which I suppose could be used in a cessation setting, and maybe the kind of cessation help that's offered to patients could be different if they are diagnosed as being dependent as opposed to someone who's not diagnosed as dependent. But there's still a lot more work that needs to be done to get there. So, thank you.
Okay. Any other questions? If not, I've got one more question. I'm not going to let you go so easily. And that is, how many items are there in the current screener that you've validated?
This has 10 items.
10 items, right. So if it was going to be a practical tool like the Fagerstrom test for nicotine or cigarette dependence is often used in a clinical setting, even with just one question, it would be great, wouldn't it, to be able to test and see whether you can get the screening down to just a handful of questions that people in a clinical setting could use, perhaps, in smokeless tobacco use?
Yes, absolutely. This item, though, I'm not sure if any of the items can be taken out of the scale and just used as an item in itself, but I did find that the scale, as I showed with the logistic regression, that it was, I was able to validate it against the chewing within 30 minutes of awakening. I found, because I administered the Fagerstrom test as well, and I found people found the tobacco dependence screener to be easier to understand than the Fagerstrom because they were all yes or no questions. And in that, because the Fagerstrom, some of the items have 3 options, and you sort of have to present them with all the options so they choose the right answer. But so they, even if it was 10 items, people found it fairly easy to get through those 10 items. I found so. Yeah, I think it's a fairly acceptable and usable tool in the field.
Great. Well, perhaps if you do develop something further, you can put your name to it and become famous in the future, like Carl Fagerstrom has. But that's great work. Look, any other questions at all? Otherwise, we'll move on to our next speaker. Thank you so much.
Thank you very much.
Thank you. Our next speaker is Raj Panda. Is Raj Panda in the room? Oh, maybe we have to skip this speaker.
If Dr. Panda does turn up, he can come at the end of the session. So we have another two speakers, which is great. So the next speaker is from India, and this is Chinna Gali, and he's from Karnataka province, Bangalore, in India, and he's going to be talking to us about tobacco cessation counselling and treatment adherence among tobacco-consuming TB patients in Kalburgi. Thank you very much.
Good afternoon. This is Kirankumar Reddy from India, working with the union. So, my abstract, the study is a bit about the role of cessation counseling of the National Tobacco Control Program in the among the TB tobacco consumers, TB patients who are tobacco consumers, how effective this tobacco cessation counseling has taken place. And next. I'm unable to see. No, not edible. Anyhow, I'll take help. So as per many of the observational studies, it is significantly shows there is a relationship between the tobacco consumers, there is a cessation counseling plays a significant role with especially to treating in the outcomes of the TB patients. And observational studies have TB associations between the tobacco smoking and the poor TB outcomes. So the objective is to assess the effectiveness of the tobacco cessation counseling and the treatment outcomes among the TB patients. The process is as per the Global Adult Tobacco Survey, there is 275 million tobacco users in India. It is estimated more than that 1/3 adult use tobacco, some other form, and active consumption of tobacco smoking increases the risk of the tuberculosis infection to 2 times, and it is significantly associated with the recurrent TB and TB mortality. And observation studies have been shown association between these two, tobacco smoking and the poor TB outcomes. So the methods we have taken up to quantify the efforts of it is the integration between the National Tobacco Control Program and the National TB Control Program. We have adopted the help coordination between the Tobacco Control Program counselors. They have played a vital role to provide their counseling for the TB patients who are the tobacco consumers. Initially, we have done the mapping for that. We have taken 2,000 mapping for the pre and post before intervention and after intervention. We have observed the tobacco cessation counseling results, and we have comparative study, we have made it, and preliminary results are assessed while the counseling was provided at the hospital level as well as the community level. It is a patient-centric approach and a comparative study to quantify the results before and after the intervention. And these are the results, and if you see for 2014 and 2015, we have before intervention and after the intervention of the tobacco counseling. Majorly the tobacco counseling, in the cessation counseling for the TB patients, we have taken the 5 R's and 5 A's, which are the mostly universal formulas, especially dealing with the counseling the patients, and in order to quit the smoking as well as tobacco consumption. So the counselor uses these models for in the cessation counseling. So if you observe that default rate for the 2014, it was 13%, while after the intervention, the rate was came to 7%, whereas the failure rate was 4%. After the intervention, it was reduced to 1%. And the death rate, if you see, usually in 2014, it was 10%, and it is reduced to 6%. These are the major thing, and we have studied in 2014 372 patients, out of which 251 TB patients are tobacco consumers. Whereas in 2015, we have 315 TB patients and 212 patients who are the tobacco consumers. So those are the tangible results we got. And so the intervention concludes that cessation counseling of the among the TB patients, tobacco consumers plays a vital role, and it is very essential to inter-coordinate the two departments, as well National Tobacco Control Program as well as the National TB Control Program. So the good coordination gives the vital results, and there is a decrease in the default and death rates, especially in the outcomes of the TB patients. That's it. Thank you.
Thank you very much. Any questions? Yes, we've got a question. Thank you.
Thank you for your presentation. I'm Okado from RIT Japan. So what happened to the smoking quit rate among the before the intervention you introduced and then after the intervention you introduced? What happened to the smoking rate? Smoking rate. What happened to the smoking? I understand that the TB treatment outcome improved after the ABC, 5R, 5A, 5R intervention. But what happened to the smoking quitting rate?
Yeah.
Or smoking rate, anyway.
The reduction in the smoking?
Yeah.
You're asking?
It was about 2/3 were tobacco users at the start. So what proportion were tobacco users after the intervention?
Yeah. So we have among the tobacco consumers, majority level is smokers only. It is almost 75%, 78%. And the remaining all the tobacco, other product consumers. And we are able to that out 75 tobacco smoking consumer smokers, we are able to reduce to the reduce for the treatment during the treatment part absolutely for the 48%.
From 70% to 48%.
48% we are able to reduce, and that means completely stop during the process of the during the treatment of that 1 year process, a 6 to 8 month process.
Okay,
and there is still we are making the final paper. We are segregating for the socio-economic indicators as well as other indicators, the bifurcation tobacco product wise. Thank you.
Hi, I have a few questions.
Yeah.
So first, you mentioned counseling was provided by the National Tobacco Control Counselors.
Yeah.
Is that true? So they were based at the TB program, TB clinics, and providing counseling?
Actually, the National Tobacco Control Program is independently functioning. And the National TB Control Program is independently functioning.
Okay.
And whenever the patient comes for intensive phase to consume the dots at the respective health facility, these counselors are interlinked with the patients. Once they complete the dots process, they were sent to the counseling weekly once in the first 2 months. Okay. And during the counselors, tobacco cessation counselors' home visits, these counselors' addresses are provided. They made the home visits to the counselors as well as the family members.
Okay, so the intervention was provided by the counselors at a different place. Patients were referred to them.
Yeah.
Okay. The second question is also about counseling. You mentioned it was a weekly counseling. So how many sessions did one patient receive on average?
During the first 2 months of the intensive phase, there are 8 sessions of counseling. And after that, they have another 12 sessions of counseling. And even the patient is not traceable in the respective area. We were traced with other health staff, and we are trying to complete that total 36 hours of sessions of counseling for during this period. Minimum 36 counseling.
Minimum 36 sessions.
And we have also attached to some of the smokers to the rehabilitation centers, which was run by the government as well as the private, those who are affordable. And that was...
Thank you. And my last question is, it's not a question, it's suggestion. So I think you have very rich data at hand, and you've done a lot of work. But are you considering doing advanced analysis?
Yes,
so controlling for confounders?
Yes, actually we are now in the process of developing the full-fledged paper, and we have taken the different cohorts groups also, and we are doing in Union software Epidata. Okay. We are doing the data entry, and we are taking the different socioeconomic indicators and how the interpersonal counseling role has played vital role, what is the grading of that counseling, how effectiveness it is, and how best cost-effective counseling can be provided at their doorsteps as well as the health facility level.
Okay,
thank you. Thank you so much.
Thank you.
Thank you. We have two other questioners. This is good. If you can just state your name and where you're from, that would be great.
All right. My name is Rana. I'm from Sudan. I have two questions, actually. The first one, part of it were asked already, but I'm interested to know, during the counseling, did you record any information about when the patient really quit, for those who quitted smoking? I mean, do you know, for example, this proportion of the patient quitted the smoking during the first 4 months of intervention or after 6 months of intervention, or?
Yeah. Actually, before starting that TB treatment on the DARTs, we have counseled that screened all the TB patients for the tobacco consumers, and we have also provided that during that 5 years counseling, we used to ask them and assess their previous history of the smoking and how they started smoking and whether they are willing to quit, whether they are, we have done the different motivational with the 5 hours. And these are the things we have considered, and we have done the mapping for that.
So I'm just interested to linking to know how to link this the counseling period with the quitting time. So, for example, if you need like 6 months of counseling to the TB patient to convince them to quit, or do you need a shorter period or a longer period? Did you consider any of this?
Yeah. If we analyze our data micro level, we come to see that quitting of counseling, whatever we got that 48%, that patients, they were used to stop or quit the smoking at the period of, during that 5th or 6th month, the high yield of quitting of smoking. Initially, first 2-3 months, there is a reduction in the smoking consumption, we have seen. But the yield we come to understand that it requires at least a minimum 6 months of continuous counseling and follow-up to the patient as well as the family members in order to give the good result.
Thank you.
Thank you.
Thank you. And I think we have one last question.
Anne Jones from the Union. Thank you for this session. It's been very helpful, I think. I think my question might be more for the panel in general, but we know that the 5 A's is a very effective intervention. I'm just wondering if we are doing more to evaluate perhaps some of the newer mobile technologies that might help in interventions in high-burden countries. And I don't know enough about it myself, but I was hearing at this conference about, how you can measure lung health, for example, and that can be done more easily now, not with a spirometer, but with a mobile phone and a sort of an adaptation, as well as using mobile phones for measuring carbon monoxide. So I'm just wondering do we have any new information about the effectiveness of different and newer technologies that we might use in counselling or to support counselling? Because there seems to be a growth in different ways now with M-Health and M-Quitting and so on. There's a number of new projects that are emerging to help in the quitting programs that you're going to be perhaps running not only with TB patients, but TB patients who smoke as well, or chew tobacco.
In this study, during this process of cessation counselling, we have used the standard tools of counselling. we have not adopted any modernized technologies for the counseling, since it is mostly, we used the information education material like flip chart model, or audio-visual aids to quit the counseling. We have played the different short films to educate these patients who, whenever they come for the for the patient provider meetings, during the monthly patient provider, we used to have this coordination with the TB department as well as the tobacco control program counseling, and these are the basic things we followed during that. But it is rightly taken that modern counseling technologies will be surely incorporated in future process. Thank you.
Thank you. It's just yep. Microphone. Use the microphone.
That's a well-taken question, madam. And rightly, like in this century, we need to make some advancements on form of technology and use that technology for improving the TB treatment outcomes among the smokers or the smokeless tobacco user. But it's like highly unfortunate on our behalf, on the part of the country, like we don't offer TB cessation services at most of the centers except tertiary care centers, in which we give nicotine replacement therapies followed by counseling. Counseling alone cannot do wonders, but counseling along with some of the therapists can do wonders. As he's my colleague and he's working as another consultant in one of the states, TB control program as of in most of the states of India has not yet provided some of the counselors. That's the mainstay for any of the cessation services. But yes, the National Tobacco Control Program has provided counselors. They do help in sometimes, and like in one of the districts in which my colleague has experimented this work of providing 36 counseling sessions to a TB patients, that is huge. And with a burden of TB, it's likely impossible for us to provide the services. And the integration of newer technologies is not on the cards right now. So we need to make some newer models. And in some of the models, like I belong to PGI Chandigarh, which is one of the pioneer in tobacco control services provided to the India. They have provided a model in which whenever a TB patient comes in with a history of daily smoking or daily smokeless tobacco users, they do provide a dependence test, which method I have taken. It's a non-invasive FT&D scale. And after that, they chart out whether it's a severe dependence, it's a moderate dependence, or a low dependence. And after that, they do plan accordingly. But the services are exclusive and provided to some of the guys. But on a large scale, on a public health measure, this is not yet done.
Thank you very much. That's good. You can go and sit down. Let's show our appreciation to Dr. Gali. Thank you. And I think it's a really good question from Anne, actually, around how do we reach people. We have these models of intervention, both for treatment for TB and also for tobacco use. But are we making the most of the available technologies and infrastructure to reach out to perhaps the rural poor in many, many countries, and where mobile access now is pretty much, well, it's growing year by year. It's not quite universal, but it's almost there. So I think there's some real opportunities for doing some great research in countries like India in this space, and we hope that some of the expertise that's developing here from our speakers' work will be able to be used. We have some opportunity to sort of have some other general questions for the panel. I just have one other question, which was around the use of the 5 A's. And if people may not be familiar, but there is actually a union guide for smoking cessation in TB settings, and that's called ABC for TB. So it uses the ABC model rather than the 5 A's. And that's been tried and tested in a number of countries now. Bangladesh, Indonesia, for example, and there have been publications on this work. So you can go onto the union website and access that guide. It's a few years old, but essentially it's still very, very good. And there's also some examples of forms that can be used to help capture the data, to track and monitor and improve the quality of the services that you're able to deliver in TB settings, centres for people who are tobacco users. Now, has anybody got any other questions for our speakers? Or any other comments that you'd like to make at this point? Yes, thanks, Amara.
So I'll just briefly comment on the same thing. So there are two things. One is the TB tobacco cessation, which is an upcoming technology that World Health Organization is working on. So how it works is it will be text message-based intervention for TB patients that will help them quit and that will help them adhere with their TB treatment. So that is one new thing that is under development, and it is being pilot tested in Egypt at the moment, but will be rolled out to other countries if it is helpful. So that's one thing on the lines of what Anne was saying and all the problems that you're discussing. It might be a solution in the future. The second thing is we are currently testing a new plant-derived product, cytosine, for smoking cessation in TB patients. The trial is ongoing in Pakistan and Bangladesh, and we'll have the results by 2019. And it's very promising because it's a very cheap alternative to all other cessation aids, pharmacotherapies out there that the low and middle income countries and the TB programs cannot afford. So if proven effective, that might be one of the solutions for cessation in the future. And I totally agree with you that counseling alone cannot do wonders. We need pharmacotherapies and we need cheaper alternatives. So there is a lot of work going on, but it's really good to see that all of you are interested in the topic. Thanks.
Right, so I think there are several opportunities here to improve and continually develop this area of work, both smoking cessation or tobacco use cessation in general, but particularly as far as this conference is called, there's a real interest in engaging with people who have TB or are at risk of developing clinical TB because they've got latent TB. And we know all the benefits, the evidence is out there around the benefits of stopping using tobacco. But there are some great opportunities to take this area forward and improve the outcomes, prevent relapse with medications, with mobile technology and other forms of support. All of them while being cognizant of the need not to increase inequalities that already exist in the services that we can provide to people in particularly the rural and urban poor in some of the poorest countries where the burden of both tobacco and tuberculosis is the highest. If there are no other questions, I would like to... Oh, you have a question here. Great. Thank you. Come to the microphone, please. Just a bit of where you're from and what your name is. Thanks.
Hi, I'm Will Ruggard from London School of Hygiene and Tropical Medicine. Really sorry, I came a little bit late, so I missed the greater part of what you were saying. But something I'm thinking and trying to write about at the minute is the use of contingency management and cash incentives and those sorts of things and the importance of thinking about these things in TB control. Tobacco is something that, especially in the literature that I read, that's just not mentioned, but is so important. So I was just wondering whether what your opinions on this were, and whether there was any work being done on this space. Thank you.
Right, so contingency management. Does anybody here, you might like to explain for those who don't know what you're talking about exactly. Can you just give us a brief definition? I'll put you on the spot, and people may be using different terminology to describe what you're talking about. Thanks.
Yeah, it's based on reward. So you try and change somebody's behavior in a way that makes them think about the health implications of a particular behavior that gives them a lot of satisfaction. So smoking, there are many reasons why you might want to smoke, but giving somebody money and trying to stop them also forces them to think, well, actually, what are the other impacts that smoking's having on me, and maybe I can replace that in some other way. Sort of, someone might.
So
be able to
are you talking
explain
about financial incentives, for example? Would be an example, and I think this has been used in some countries, particularly for women who smoke during pregnancy. There's some good evidence around that, and there's a growing body of work in this space. But do any of the speakers know about whether financial incentives or contingency management techniques are being used in your fields of work at all?
Yeah, like if I'm not wrong, like providing financial incentives. Was that the opinion from you? Yeah. In some of the parts of the country of India, like financial incentives for tobacco cessation took up in a very small scale among few thousands per 2,000, per 3,000 population, and piloted on a very small scale of providing financial incentives to around 10% or 20%. But like, as we know, like in a public health and on a public health domain, behavior change by finance is a distant dream, except like in institutional deliveries or somewhere like where we are encouraging the health system strengthening, we are putting on financial incentives to take up the services. But in a behavior in which there is a crave, there is a need for tobacco, like getting that nicotine, financial incentives should be such high that it alters the socioeconomic status of that patient or that person. If it does not, if the amount is not good or the incentive is not good, then it's not going to work. That's our experience. Providing a small, meager financial incentive will not help, except providing something like that attracts him. In one of the surveys, like in Mumbai, if you have heard, like we came across some of the patients who outrightly said, no, financial incentives at one point of time will help me for the same day, but in a long run of 6 months, 4 months, it's not going to help me. Or you can benefit me by providing a continuous support for the entire 6 months or 4 months, so that I will be able to, like, behavior change can happen. And also some of the theories of behavior change says completely that, like, not less than 6 weeks of continuous embarging of the same thing does make a behavior change. Behavior change is the last thing and the most difficult thing that one can achieve by providing simple financial incentives. Thank you.
Okay, thank you very much. I think on that note, we will wrap up our session, and I'd like you to join with me in thanking our wonderful speakers. And if you want to speak with any of them, including any of the questioners who've raised interesting issues, please feel free to stay back. And before we just have a round of applause for our speakers, just to let you know, there is a working group that discusses these matters, tobacco cessation and TB, and also HIV. So if you want to join that working group next year in The Hague, you can do so. You can contact Omara, and she will email you and get you in the loop. And if we're lucky, we may be able to get a workshop as well. We had one this year as well, but not many people turned up. I think they got lost. So let's thank our speakers for a great series of presentations. Thank you very much. And thank you for joining us this afternoon.